And most of them are actually JAMA articles. So I'm not quoting surgical journals here. It's been around from the early 2000s that we don't have evidence to support that trying non-surgical methods is going to help. Now, but I want to throw this in. It does not mean that anybody who comes in with excess weight, let's take them straight to the operating room. Absolutely not. It just means that you have to have realistic expectations and goals when you have the conversation with the patient. If the patient is 250 pounds above the ideal body weight, no diet is going to help them lose the 250 pounds. It's going to help them lose some percentage, but will that translate into resolution of diabetes or medical comorbidities? No. And because we don't have any evidence, we have all the evidence suggesting that it will not. However, there are always individuals who achieve tremendous weight loss and they're able to sustain it. And I believe that everybody deserves that trial. So if I have to see a patient today in the office, there's the first 2 or 3 pages of the questionnaire that they fill out is only details about what are the weight loss attempts that you have tried in the past. And if they haven't really tried anything significant, like they'll try for a couple days, couple weeks, off and on, then I recommend all of them to join some kind of a structured weight loss program. Because if they can lose weight with that, if they happen to be that minority of patients who can do that, that's great. Because there's no emergency weight loss surgery. They did not get to the weight overnight, and they will not get off that weight overnight. So this is an area that we can work together, and also the basis of, as Dr. DeCosta alluded to, the medical wing of the Metabolic and Bariatric Center, which is just as important to me as the surgical wing. So we call that the medically supervised weight loss program. It's a 6-month program structured purely on education. In other words, we don't print out a 1,200 calorie menu and say, here, follow this, because now you can Google and you can print out many different kinds of sample menus, I'm sure in many different ethnic food as well. But that's not the goal of medical weight loss. The goal of medical weight loss is really education, so that even if they do get surgery at some point in their life, they know what to do to help maintain the weight loss. Because I'm sure all of us have seen people who've undergone some kind of weight loss surgery and then a few years later they regain the weight. And in my opinion about that class of patients is, the patient was not ready for that operation. So you have to put a lot of time and effort in getting them ready to that point. And the time and effort is, as you can imagine, is one of my biggest challenges. To get them to come to the medical weight loss program, to be regular, because I can educate them, but I can't eat right for them. I have a personal trainer in the program, because when I would go to the gym, you sign up for the gym fee. Then if you want to do work, anything extra with the personal trainer, you have to pay something extra to the personal trainer. When you go to these classes that some of the gyms will offer for free, the first 4 rows are young females with perfect figures. And in the corners will be hovering, some of the bigger sized people. So they are not getting the attention that they need from the personal trainer. And if I tell my patient, go join the gym, I know what the gyms look like. So it doesn't, it's a waste of their time and effort, and it's not going to help me get them to exercise more, which is the basis of us getting a personal trainer to the program. Now this is another story to get the patient to the personal trainer, but at least I can do the best in getting that quality program, and then something that I hope that we can partner together in encouraging our patients to do that. And I want to highlight this, that we don't take a single penny from what the personal trainer gets. And I'm grateful for the administration to help me in this. So the personal trainer right now that we have comes from Jersey City. He will sign up with the patients, and whatever he charges, which is $15, $15 for a class, which I don't know if you guys know about personal trainers. I can't get anybody less than $45 for a 1-hour class. But he is passionate about wanting to make a change in this area, and so his price is very, very low, and the money goes directly to him. The hospital has spent money buying the equipment, getting the room, without getting a single penny back, just as a service for the patients. And I'm grateful for the administration to help me support this part of the program. I was asked months ago, how important is the exercise part of the wing to you? And I'm like, just as important as surgery. And that's the message. With obesity, if you just take care of one thing, let's just get them to exercise and not address the others, you're not going to see the result. If you just do surgery, we don't do the others, you're not going to see the result. The result I'm saying is not how much weight they lose in the first year, is sustained weight loss with the resolution of comorbidities. It's a tough battle to fight, but in my opinion, the only way to do it is to work on all of these aspects together, which is the basis of our center. So our team right now, I'm going to transition over to tell you guys a little bit more about our center. I'm very, very proud of our team. I've been here for 6 months in St. Michael's, and I'm very grateful that I've been able to get a core group of people who are passionate about obesity, who do this just not because it's a job, who don't look at the time and say, you know what, it's 4 o'clock, I need to go home. They really are passionate about this. And we have our dietitian, our own psychologist, we have a personal trainer, as I mentioned to you. We have the capacity of the obesity medicine specialist, and Dr. Patel's group is helping us fulfill that need. I'm very grateful for that. I kind of dragged him into this because I couldn't find an obesity medicine specialist. And then myself as the surgeon, and of course my administrative staff, Paula, and our nurse coordinator, Annette. So a lot of people put together, because it's just as I mentioned, we have to work on a lot of different aspects together to help get the patient to where we need the patient to be. So we have the non-surgical part and the surgical options, and I have mentioned the non-surgical part. What the principles behind our management approach to obesity is medical and/or surgical, nutrition counseling, exercise programs, and behavioral modification. So a patient can be plugged into the medical weight loss part or the surgical part, or he would go back and forth between the two depending on where the patient is in his journey against obesity. But the things that will be common to these two wings is the nutrition counseling, the exercise, and the behavioral modification. So let me elaborate about this. So the behavioral modification is, they meet with our psychologist. If they need more sessions, we set more sessions up with the psychologist. We have a monthly free support group that Annette conducts, and we have a preoperative education class, and then we have a post-op class. Just keep on sitting with them and trying to break it down about how their life is going to change or needs to change to be able to get that result. Nutrition counseling, the medical weight loss program is where this plays a big role. In the surgical, it's pre-op nutrition counseling, and then post-op, which is pretty structured. They have their diet laid out from week to week up to like 8 weeks out, and they have to follow that. For the medical weight loss part, it's a 6-month program. The first 3 months is weekly visits with the dietitian, 1-hour group setting. I chose the group setting model because I think patients need to be each other's support, and it has worked out really nicely. We have an evening group and we have an afternoon group, and the same group then signs up with the personal trainer. So they keep check on each other, and they get weighed every week on the same scale, which is our scale. So it's not like my bedroom scale is different than my bathroom scale, and today I was wearing heavy shoes and yesterday I was not. So we keep it very objective. And then one of the important parts is I check the vitamin and mineral levels. So contrary to a lot of people's belief that obese person cannot be deficient in vitamins and minerals, a lot of data to support they're actually very deficient. And I believe that in the past, when bariatric surgery was associated with significant vitamin deficiencies, nobody checked the vitamins before they were taken to the operating room. I bet you that if we did, we would have discovered these vitamin deficiencies even before they went to the operating room. And of course, that post-op the vitamin deficiencies are only going to get worse. So as a protocol, every patient who walks through the office, whether they go into the medical weight loss program or the surgery, they get their vitamin levels checked. And then the vitamins that are available in the grocery store are not, most of them do not work. And the reason why is because vitamins don't taste good. And the companies develop a shellac, a tastier shellac or coating outside the vitamin itself, which requires acid for its breakdown. So after bariatric surgery, especially after gastric bypass, there should be no acid in the pouch. So the patient who's putting that pill in does not have the acid to break that down. In other words, they're spending money buying vitamins, they're not going to be absorbed, and then you're like, either the patient is not telling me the truth about taking vitamins, or their vitamin deficiency gets worse and worse and worse before it gets picked up. Patients on PPIs, and a lot of them with obesity have GERD and reflux, their stomachs function the same way. They should not have any acid if they are taking the medication. So their vitamins will not be broken down also. There are 1 or 2 companies who make those vitamins that do not require acid. Bariatric Advantage happens to be one of them. I have no stocks in that company, but that's the reason why I have no stocks in any company right now. I want to keep it that way. But that's the reason why we brought their products into the office, because just like I can't trust the gyms out there to provide the right exercise, I can't trust the vitamins out there. And I use their vitamins myself because I have heartburn and I take PPIs occasionally. So I know if I take the vitamins from over the counter, from the grocery store, it's not going to work. So that's also an important part, again, common to both medical and surgical.